a few kind of key things to highlight. First, that there's never been a greater sense of energy, hope around MPNs in terms of new therapies being developed, a new understanding of the biology of the disease, new potential in the future. So let me break down just a couple key highlights. One, on the science end, there was what we call the plenary abstract. So at the meeting, a meeting of thousands of abstracts, they pick out the 5 or 6 that they think have the greatest potential to have an impact. One of these was specifically in MPNs, where in laboratory models, so it had not yet been tested in human patients, but an antibody which uses kind of the immune system to target calreticulin that is specific to the calreticulin mutation that patients with ET and myelofibrosis can develop, and that can be present in about a third of patients with ET or myelofibrosis. And that appears to be very promising in the lab. So that's going to translate into a clinical trial that will be upcoming, potentially for subgroups of patients that have the calreticulin mutation with myelofibrosis or with ET. So more to come, but a tremendous amount of excitement around that. Second, in ET and PV, many exciting things. New therapies that are in development that are being discussed, from IMG 7289 that's going to open up in a worldwide phase 3 trial for patients that have failed hydroxyurea, to further updates around interferons, long-acting benefits and deep impact in PV, increasing information and benefit in ET, and ongoing accrual to studies like the SURPASS ET study, as well as data both in early myelofibrosis as a single agent with ropegylated interferon alpha 2b, and a very interesting trial of interferon and ruxolitinib together for patients with myelofibrosis that had not had ruxolitinib, the JAK inhibitor, before, suggesting that that combination may be attractive and beneficial. There were many updates regarding the new therapies in myelofibrosis. Further updates on therapies already available to us. With fedratinib, greater long-term data regarding the safety and the effectiveness, both in the frontline and second-line setting, and continues to be a very valuable drug for myelofibrosis. In pacritinib, more data that helps to show the benefit of pacritinib for anemia, some of the biology behind that benefit with the inhibition of ACVR1, and now pacritinib approved since February of this year, very important option for patients with myelofibrosis with lower platelet counts. We had many abstracts, and I was involved with several of these, on momelotinib, a JAK inhibitor that can also help to improve anemia. We presented data on the durability and the extent of benefit from the trial that was the Momentum study. This was a second-line study for patients with myelofibrosis. Symptoms, anemia, splenomegaly, continue to show benefit and durable responses now at 48 weeks and kind of continuing on. So all of that very favorable. I would really anticipate and hope that momelotinib may become available kind of somewhere in the middle of 2023 for patients with myelofibrosis with anemia, hopefully for those either in the frontline or second-line setting where that's appropriate. There are many combination studies that are being discussed and presented, as well as ongoing phase 3 clinical trials of ruxolitinib with pelabresib, the BET inhibitor, good durable benefit and data, as well as evidence of some disease modification. The combination with navitoclax, either upfront or as an add-on for ruxolitinib to really help to improve splenomegaly symptoms, and all of these combinations perhaps to a greater degree than either drug kind of on their own. Many other drugs in that mix, parsaclisib with ruxolitinib, as well as multiple new agents that are being looked at. There probably are conservatively between 6 to 10 medicines different than JAK inhibitors being added to JAK inhibitors, either upfront or in combination during the course of therapy, that will have a further impact on the disease. So many exciting things, and this is just really scratching the surface of truly the hundreds of abstracts really being presented on MPNs here at ASH. Now, what does this mean for you? Well, for patients that are doing well on whatever therapy that you're on, and discussing that with your doctor, letting these things kind of work their way through for us to figure out which patients benefit is probably the best. If you're already doing well and stable, changing may not make sense. However, it is a period of time if your disease is not in that category, it's not stable, you're not feeling well, your spleen is growing, you have ET and PV, and the current options you have aren't working well, it is very possible that there may well be a clinical trial that might benefit you in ET or PV or MF, and certainly would suggest that you ask your doctor about that. Are you happy with how I'm doing? Is there a clinical trial that might be appropriate for my situation? And if so, perhaps connect me with such a trial if appropriate. But let me leave you with this message really in the spirit of hope. Having been in this field now for many years, the rate of progress is tremendous. The number of people involved is really astonishing around the world. And I know together we're going to continue to make a deeper and deeper impact to decrease the impact that MPNs has on patients like yourself.